Hello, everybody. Just wanted to welcome you to today's webinar. My name is Dominica Murphy, and I'm the Community Director of Surround Health. I hope all of you are doing wonderful today. We have a terrific webinar planned called Motivate Resistant Patients by Changing Your Professional Role with Dr. Rick Botelho and also a terrific group of panelists. So just a couple of housekeeping rules. So during the webinar, if there are any questions, please type them into the questions section on your control panel. We will be taking them at the end, so if anything comes up during the webinar, just feel free to type it there and we will get to it in the last 15 minutes. We are also tweeting during this webinar, so if you're on Twitter, we hope you can join us at the hashtag #SHWebinar. We are also recording and archiving this webinar, so it will be posted on Surround Health. So if there's any portion that you missed, don't worry. You can check it out at a later time or date. And we have been pre-approved for RD credits, so just be sure to complete the feedback survey at the end. You can also earn 2 extra credits. So altogether, we were pre-approved for 3 RD and CHES CEUs. So if you're still interested in getting the 2 extra CEUs outside of this, we have extended when you can post your reflection notes through Wednesday, May 14th, so that's 1 week. So we certainly encourage you to do so if you haven't had a chance already. And for those, you will be receiving a second certificate via email once you complete the reflection note. So I did want to let you know that today's webinar is going to be done in a very different format than I'm sure you're typically used to. So we hope that you do find it useful and that you let us know your thoughts about the format in our evaluation at the end, whether or not you thought this was good or any other feedback you might have for us. So we just wanted to start off doing some quick polls to gain an understanding a little bit more of how many of you had the chance to download the chapters. So I'm going to launch a poll right now. So if you could just take a minute to please respond to the question, how many of you were able to download the 3 free chapters of Motivate Resistant Patients book? Great, thank you. So I'm seeing some responses coming through. Perfect. So we're seeing 42% yes, 49% not yet, 5% I will download them now, 8% no, I will not be downloading them. Okay, thank you. So I'll just close this up and I will share the results with you just so you can take a look. So as you can see, 39% yes, 48% haven't had a chance to do so yet, 5% they will download them now, and 8% no, I will not be downloading them. Great, thank you. So the next quick poll, for those of you who did download the chapters, can you please respond to the following question? So yes, I read 3 chapters. I read some of the 3 chapters. I intend to read some or all of the chapters, and I will not be reading the chapters. So we'll just take 30 seconds more for that. Great. Thank you so much. So I am now closing the poll, and I will display the results for you. Okay, so it looks like 4% read all 3 chapters, 22% I read some of the 3 chapters, 62% intend to read them in the future, and 12 will not be reading the chapters. Great, thank you. So just one last quick poll, if you could just help us by answering. How many of you, I'm just going to launch it now, I apologize. So how many plan to read the 3 chapters and post your reflection notes on Surround Health to earn the extra 2 CEUs? So we'll just take 30 seconds for that. And the responses are, yes, I have already done so. Yes, I will do it. I doubt it, and no. Perfect. So we'll just close this up and launch the results. Okay, perfect. So it looks like 0 said I've done so already. 49% yes, I will do it. 29% I doubt it, and 23 no. Great. Well, thank you all very much for participating in these polls. They're really helpful to us. Okay, great. And now I would like to turn it over to Dr. Rick Botelho.
Well, thank you, Dominique. I wanted to thank Susan, Dominica, Sarah, Tami, and Joanna for participating in this different type of learning experience. And as a small gratitude of my appreciation, I'm going to provide them with free copies of my book, and we'll also offer a special offer at the end. Let me just explain a little bit about the reason for asking those questions. I wanted to explain the rationale, because the measuring behavioral intentions, we're inviting you to consider whether you'd be interested in changing your learning style. And hopefully this webinar will demonstrate a different type of learning process. But let me just tell you a little bit about my personal story about how I became interested in this whole topic. It actually started right at the very beginning of my career back in the late 70s. And my interest arose because I had this opinion that my professional education was totally inadequate in addressing the complexities of health behavior change. And so about 15 years ago, I decided to write this book, Motivational Practice, that integrates a wide range of theories and practices, such as the stages of change, motivational interviewing, social learning theories, self-efficacy, and self-determination theory. Now, having said all that, most practitioners aren't interested in theories. They just want to learn what they can do better. And so the design of this learning process is to help make theories, concepts, and methods fit the needs of the patient rather than making the patient fit the needs of our models. So could you forward the slide for me? For some reason it's not moving. There we go. I can't move the slide forward. For some reason it's not working for me. Thank you. And next slide. And so this is going to be a learner-centered learning format, and at the end of each of the chapters it invites you to reflect about your learning lessons so you can explore your sort of leading edge and enhance what you do. Next slide. Now, I want to jump ahead. Now, the learning-centered outcomes of this particular session is to know the differences in the role types between the fixit, the motivational, and preventive roles, and to better understand how your professional role shapes your clinical behaviors. And lastly, how to adopt a motivational role so that you can develop motivational skills more effectively. Next slide. So anyway, the benefits of this, of going through this learning process, and I'm going to jump to the end and say why even bother getting involved with this, is how can you reduce your frustrations in working with so-called resistant patients, how to engage patients in change dialogues over time, and how to develop individualized interventions that create effective action. Next slide. And the benefits are, how can you enhance the patient's readiness to change, how to enhance their patient satisfaction outcomes, and how to enrich your professional experiences. Next slide. So what I'd like to do here is to use a metaphor. And this is what I would call the disease iceberg metaphor. The tip of the iceberg is the disease, such as diabetes. The bulk of the iceberg below the water surface is the pre-disease state, such as pre-diabetes. Now, the freezing water is the epidemics of unhealthy habits. And what's actually happening is the iceberg is getting bigger, not smaller. And this is where actually global warming could become helpful, because if we can actually develop motivational skills and help patients develop healthier habits, we can actually melt the disease iceberg. And so what I'd like to do is just take a 3-second pause here just to sort of reflect about this metaphor. Next slide. So what we're going to be doing today is actually sort of demonstrating how we can have learning conversations about behavior change. And in a moment, our 3 panelists are going to introduce themselves. Next slide. And what they were invited to do was to summarize their important take-home message from the reflection notes from each chapter, to answer the question, why is this learning important to you and to others, and how will this new learning enhance your work as a leader, administrator, educator, or clinician. Next slide. So what I'm going to do is I'm going to give a summary of Chapter 1, just a few take-home messages. And the bottom line about this chapter, which is something that isn't really taught very much in professional education, is that we need to learn how to change ourselves, personally and professionally, before helping others, each other. So I would like to go on to the next slide. Next slide. There. We've actually skipped over a slide here, but that's fine. Just leave it here. And the fixit role is about giving information advice, addressing surface change, and surface change is about increasing knowledge, setting goals, and eliciting good intentions. And as we well know too well, knowledge alone seldom changes behavior. And so what I'd like to do is to introduce another metaphor, the hammer and nail metaphor, which we're all familiar with, which is we've only been trained to use hammers, in other words, give information and advice, we tend to see people's risk behaviors as nails. Next slide. Now, patients are more like nuts rusted to the bolts. And the issue is if we keep on hammering away at patients, we may actually damage the threads, the bolts, the nut never comes off. And this brings up the possibility that inadvertently we may be making patients more resistant to change. Next slide. So we need to shift our metaphors from mechanistic metaphors to organic metaphors. Next slide. And for this, the metaphor I'd like to conjure up here is the metaphor of the gardener. The motivational role is a gardener. Next slide. That's cultivating the soil. Next slide. Fertilizing the ground. Next slide. And planting seeds. Next slide. So I just wanted to encapsulate what Chapter 1 is about. And what I'd like to do now is to shift gears to our panelists. I was just giving a brief introduction to Chapter 1, and I'm curious to learn a little bit more about what our panelists learned from going through this learning process. And so I'm going to ask Joanne to briefly introduce herself and to summarize her take-home messages and how this might impact her future work. So Joanne, could you briefly introduce yourself?
Sure. My name is Joanne Rinker. I am a certified diabetes educator and a registered dietitian. I have been a dietitian for 12 years and a CDE for 10, and also just recently named the 2013 Diabetes Educator of the Year by AADE. Probably because of the work I'm doing currently with the North Carolina Division of Public Health, working with local health departments around the state, starting and getting recognized diabetes education recognition programs. So that's kind of what I do and a brief intro on me.
And so would you like to summarize your take-home messages from this chapter?
Yeah, so one of the things I think is really important, and it was actually one of the very first things that is mentioned in Chapter 1 that I think had a variety of meanings, which was, the very first thing was consider changing yourself before helping others. And so I thought about that in a variety of ways. One is consider changing yourself as far as being a role model. Are you a role model to your patients? So in a tactful way to say this, when you're telling your patients the importance of exercise and eating healthy, are we also doing those things, and are we setting that example for our patient? I know that that could be one of the things that we all could probably work on to do a little bit better. And so when I was reading that, I was thinking about, that plays a role in the response from the patient. Additionally, I was thinking that that also means changing ourselves as far as changing the way we work with patients. And so it is a lot of times that we are giving information to patients, telling them about a lot of the things that they need to do to improve whatever their health status is. I mean, like I mentioned, I work with patients with diabetes, so that is my focus. And so I always want to make sure that they leave knowing how to monitor their blood sugar and when to take their medications and what they need to do as far as a meal plan and exercise. But, there is a big difference between giving the information and talking with the patients about what exactly they can do to make some changes to some specific behaviors. So, just to give an example, something like a patient who says to me, well, I do, really work hard on taking my medication every day, but I forget sometimes. And maybe instead of saying, okay, well, you really have to take your medication every day, ask them, well, what are some things that you can think of that would help you remember?
Mm-hmm.
And maybe trying to nail those things down with them instead. So instead of telling them to take their medication, thinking about how to help them remember to take their medication,
Mm-hmm. Mm-hmm.
which is a different style and kind of a different avenue, and some other things like that. And then I think another thing, especially for patients who have diabetes, is that there is some fear involved. And so, you're giving them information, but maybe they have some fear about any of those variety of things I mentioned, whether it be monitoring or taking their medicine or not being able to purchase the foods they need to have a healthy diet, things like that. So,
Mm-hmm.
so it's just really important to not just be the person giving the information, but to also be getting some information back from the patient so that you can kind of help them problem solve.
Okay. I was just wondering if there was something from the chapter that you took away that you think might advance your work in any area. Is there any sort of something where you think you might want to work on to improve?
Yeah, I think not only, for me, it's not only helping patients, and I gave some examples there, but also, I do a lot of work with educators around the state of North Carolina, but right now also across the U.S. And so I realized when I'm presenting to them about my topic, which is on hearing loss, I really want to try to make the information relevant to the person. So for me, it's whether that person is a patient or an educator, making the information relevant. So again, it's not only telling them about hearing loss, but maybe when I'm in the state of North Carolina, giving them information about most current North Carolina data.
Mm-hmm. Okay.
And then asking them about, asking educators too, what are things that I, have not mentioned that would have been helpful to you? Yeah. And being, because I think I'm probably missing some things as well. And so to get some feedback and just learning not to assume that, everything I'm kind of saying is the only information.
Right. Actually, what I'd like to do is maybe advance to the next slide and just give Tami a sort of 60-second spot to perhaps capture some points that you took away from the chapter. Tami, are you there?
Sure, I'm here. Can you hear me?
Yes. Just speak up a little bit.
Yes. So I think the most striking thing to me was similar in terms of changing myself and relating that. I mean, I immediately went to the experience of being a healthcare consumer myself. I have been working with a physical therapist and assigned to have exercises, and I remember the dread of going, facing the appointment, knowing that I hadn't followed through on all the exercises. And I really related to the part of the chapter that talks about a patient's guilt when they feel they're not being able to follow the doctor's instructions, and that could lead to canceling appointments or follow-ups, or trying to seek another provider that's more sympathetic.
Mm-hmm.
I know that's something, as a person in public health, I often advocate that if, as a patient, you don't have a trusting relationship with your provider, you should go out and find one that you that you do trust.
Mm-hmm.
So that's kind of a wake-up call to practitioners as well. And then in terms of how I would take some of this information, I think it was very clearly encapsulated that taking or creating small steps, manageable goals, and encouraging a patient is really seeing a long-term process rather than sort of throwing one big, I want you to do this, and having the patient feel that that's not manageable. So figuring out together with the patient what would be manageable.
Yeah, exactly.
I think is something that stood out to me.
Mm-hmm. That's great. And next slide. And Sarah, would you like to add anything else from Chapter 1 that stood out for you?
Sure. I really, what Joanna said really resonated with me about how it's important to ask the patients what's going to work for them. And in our experience, in our resource center, patients who feel supported and validated often come up with their own solutions and more appropriate solutions that will work personally for them, and we see more adherence and motivation because it's something that they know will work for them and their belief system.
Okay, that's very good. Well, maybe we can move on to the next slide. And I'm just going to give you some overviews of Chapter 3, some sort of really important take-home message. Next slide. In the next slide, this slide here, what I'd like to do is to contrast two positions. There's the take charge controlling approach, which is really inappropriate for health behavior change, and the one-up position, which is actually counterproductive in dealing with health behavior change. But it's only acceptable, really, when the patients really want your expertise and taking that position as an expert. So that's one pole. At the other pole is a motivational approach. And this is being autonomy supportive. And this means really respecting patients for decisions that you may completely disagree with. And to help to facilitate change, it's learning about how to take the one-down position, what can be empowering. Now, there's a separate chapter that goes into much more details about the nuances of how to take the one-down position, which actually two of the speakers actually referred to in their commentary, which is deferring to the patient's expertise about how to solve their own problems. That's an example of taking the one-down position. And the thing about this polarity is I think most healthcare practitioners don't tend to see themselves as being taking charge and controlling. And sometimes we're much more so than we think we are. And so trying to understand the distinction is important. And this chapter provides an example of what a fixit practitioner is like compared to a motivational practitioner. So if we can move on to the next slide, I would like Tami to personally introduce herself. So Tami, would you like to give a thumbnail sketch of the work you do and background?
Sure. So I work in public health, and I have been doing a variety of public health work for 25 years. I started out doing advocacy for people with disabilities and chronic diseases, and for the past dozen or so years, I've been working as a health educator, championing health literacy and health communication, and especially involved in communication around vaccines and vaccine hesitancy.
That's great. Perhaps you could summarize your take-home messages from your reflection notes on this chapter.
Yes, absolutely. So, it struck me that non-adherence is a very common problem, and also that it's unlikely that physicians receive this specific training in working with patients. And in public health, a lot of times in health education materials, we often develop materials that lead to a specific action, and often that action is ask your doctor. So it's striking to me to see that, we're just then leaving it up to the doctor, expecting them to know how to do this this communication appropriately.
Mm-hmm.
I thought that one of the more striking things to me, what I hear a lot, and I know rightly so in the healthcare system that we have, is that taking time to do something that's perceived as extra is seen as a likely barrier from the provider point of view. I don't have time to to do all of this extra conversation. How am I going to get reimbursed for that? In Chapter 2, in the example, I found it very interesting and surprising that when contrasting the length of a motivational clinical encounter with a fixit approach, it was only a minute or two longer. Yet the payoff can be really great. And so I think that that's important information in terms of being able to break down that that perceived barrier for providers.
Tami, I think you're right on the money there in terms of that particular point, actually. And I think it's a little bit more than that, because I think it's the actual fixit practitioner is actually wasting time. And the motivational practitioner is it's taking maybe a minute too longer, but is actually involved in a much more engaging process rather than getting frustrated with a fixit ball. So I think that's, I just want to emphasize that, because I think you really tapped into something which is a major source of resistance as to why practitioners don't change their own behaviors, because of the time constraints and everything else. In terms of anything that stood out for you that might actually improve some area of your work, has anything stood out that you want to improve on?
Yes, I think, allowing the patient to feel comfortable and not rushed in bringing up questions and concerns. Mm-hmm. The example talks about asking permission to get a support person involved. That seemed really smart to me, mm-hmm. Rather than the physician dictating the terms of the clinical encounter. Mm-hmm. Allowing the patient to grant permission and to give ideas on how to improve the clinical encounter. And then I think a lot of times we advocate sort of talking points for different situations, and mm-hmm. providers may have sort of a pat answer. Oh, you've touched upon mercury in vaccines. I'm going to say this. But I think it's really important that patients or parents, a lot of times that we deal with, have a variety of concerns, and it's very important to for the provider to practice really active listening and to watch the patient's body language and to get a sense of whether they're on the right track, and to adjust as the conversation goes along, so that they're not just kind of jumping on with, this is what I think you need. I heard that one buzzword, but really individualizing the conversation, which I think will again help the patient feel heard, feel respected. You talked about metaphors, and I think of complaining to an airline about a missed connection, and one of the things I said was my first flight was delayed because of weather, but then I went on to explain the rest of the problem, and I got a form letter back saying we have no control over weather, and I was angrier than ever because they hadn't addressed my question. They saw that one buzzword, and I think that may happen in a clinical setting as well.
Yeah. I think one of the things that you're highlighting is that you really have to, one, listen. It involves a change dialogue, which means you can't fall back on your standard Q&A type of thing. And it's only out of that dialogue that you're going to be able to have some prospects of developing effective action. Maybe we could move on to the next slide so we can let Joanne perhaps add her take, a little brief message or something that stood out for her.
Yeah, so, it's interesting because one of the things that stand out for me is the engaging the patient part. And, the reason I say that is because when patients have diabetes, you do want to make sure that you mention to patients that, diabetes is progressive, and that even though you don't take medication now or don't take insulin now, that doesn't necessarily mean you won't be taking any forever. And so kind of helping them to keep an open mind that it's not a failure, and kind of exposing them to insulin if they ever have a high blood sugar in the doctor's office, and kind of communicating with them and actively just kind of getting them to understand something that may happen in the future, because a lot of times, and it's what you said before about time, a lot of times doctors won't prescribe insulin to their patients because of the time it takes to talk to them about it, to help them conquer their fears about it and that kind of thing. But really, if we engage them early on, then they may never get to the point where they have to take insulin, which would be wonderful, but if they do, then they would have been exposed to it for all this time while they were in the provider's care.
I think that's a great point, actually, in terms of preparing patients in advance that insulin may be something on the horizon, and there are things that they can do to avoid it, and if they have to get to that point, they'll be better prepared to work with a physician in order to, optimize their control of their diabetes. So.
Right, so just some engagement there early on rather than getting to the point where they do need it, and then that's when it comes up.
Yeah. So advanced planning, sort of scenario planning about different aspects of their care depending on how they'd like to manage it. Could we go to the next slide? Sarah, would you like to add anything else?
Sure. I really liked what Tami said about how sometimes clinicians will jump on a buzzword in the clinical setting, and the experience that I had was shadowing a patient in our geriatric clinic. And the patient at 86 was complaining about the cost of her medications. So the physician changed her drugs, but they weren't as effective. She ended up in the ER, came back to meet with her provider, and essentially said, "Why did you change my medications?" She said, "Because you thought they were too expensive." She goes, "I don't care that they're expensive. They're what works." And she had the ability, actually with her insurance, it was less than $20 for this prescription that was several hundred over the counter. And so just seeing that whole fix it, oh, I hear you have a problem, I'm going to fix it, without delving further into the whole scenario, caused additional visits for the patient.
Yeah, I think, Sarah, you've really tapped on something very important, and that is how do we raise consciousness about how we go back and forth between these various roles, and particularly when we regress, so to speak, inappropriately to the fix-it role, when we should really be engaging patients in the problem-solving process. I think that's absolutely key. Can we go on to the next slide? Okay. And this chapter is about adapting your role to the patient's needs. And this theme is coming up in the brief stories that we've heard. And again, I'd like to just emphasize perhaps a bit more blatantly some of the shortcomings of the fixit role. Next slide. The downside of this is that, if we don't change our professional role and we stay fixed in the fixit role, and we've all done it, by the way, I myself included, I'm not exempting myself from these things, and it's how we can become much more aware of when we get back into this role inappropriately. There's places where that role is incredibly important, but if we're locked into an inappropriate role, we're more likely to get in control issues with our patients. We're going to generate more conflicts in relating to patients, and we may not even be aware of them. We may be evoking guilt, and the patient isn't even speaking to that issue. And not only that, a good barometer is are you feeling frustrated in your work? And if you are, that could be a sign that you're actually getting stuck in a fixit role that's not working. So frustration might be a barometer of saying, whoops, am I slipping back into my fixit role and this isn't working? So there's a lot more details in this chapter if you want to delve in more deeply about role boundaries, functions, whatever, but I'm just highlighting some key points about the fixit role. So can we go on to the next slide? So Sarah, you are the lead author on this, but before we do, the lead reviewer on this, could you briefly introduce yourself?
Absolutely. I'm Sarah Christensen. I work at the Mayo Clinic in Rochester, Minnesota. I've been at Mayo for 15 years working in patient education for hematology, oncology, and medical genetics, and I've been the manager of our cancer education program for the last 4 years. We have a large resource center and staff including nurse educators, librarians, American Cancer Society patient navigators, and clinical trial referral coordinators. And I also sit on the board of the Cancer Patient Education Network, which is a national organization.
Okay, so perhaps you could summarize your take-home messages from your reflection notes for this chapter.
Absolutely. I thought it was a really interesting affirmation that both the healthcare provider and the patient have a responsibility for the healthcare issues. And there is a time and place for every role in certain situations or circumstances. So with our resource center, if a patient walks in asking about side effects from their cancer treatment, we're going to go right into fixit. Here's how you deal with your nausea or whatever problem they have. Mm-hmm. If they come in asking about diet or exercise or potential cancer recurrence, we're going to move more into a preventative dialogue. And if someone comes in asking about family history or genetics, it's much more of a motivational role about screening and the importance that can have. But because we're in a resource center, we have a lot of tools. We've got decision guides, videos, brochures, care plans, etc. So what was important to me in this chapter was remembering that it comes down to the individual interaction and that assessment is key. And we'll see that, again, with patients when they come in, they might have a very general question such as, I'd like some information on prostate cancer. And we have a fantastic staff, and they're very versed at saying, well, tell me more. What are you thinking about? And it might really be the starting point to talk about concerns about sexuality or some other topics. So assessment, I really feel, is key, and also just the self-awareness of how we each have our own individual beliefs and values and attitudes and how that might impact the interaction. And really, no matter what role we take on, it's important not to impose our values on the patient. Mm-hmm. And the example that we see with that is we do have people that will come into our center and say, I was just diagnosed, I'm not interested in treatment, I'm ready to move on to the next phase and look for some end-of-life or palliative care options. And, you know, we have to respect their decision and give them the best information that we can.
Mm-hmm. Yeah. And is there anything from this chapter that might enhance what you do in your professional work?
I think absolutely. From a manager standpoint, it's a great reminder that I need to support training opportunities for my staff, and hopefully that will increase their satisfaction, retention, and also have our patients more satisfied as well. and also provide an opportunity for the staff to learn from one another about what does and doesn't work, whether it's through role-playing, or we actually have a standing agenda item on our staff meetings about case studies. And that's a chance to talk about an interaction that went well or didn't and get some feedback from their peers.
That's fantastic. So in some respects, creating a learning community, which we're trying to model here today, and hopefully might evoke some interest from the listeners. Next slide. So, Tami, do you have any take-home messages that you would like to add from this chapter?
Sure. Can you hear me?
Yes, I certainly can.
Okay. So I think what I looked at was, like some of the other speakers have talked about, to not push your own agenda, which may be different than the patient's. But I like the idea of asking the patients to define their own goals and their own solutions. And I think, Rick, to your credit, in this book or in this chapter, you also looked sort of critically at when process is valuable and when it might be less valuable. So one of the things that I noted was that some patients may feel irritated with too much repetition or too much process. Some patients come in and they're just ready to take the instructions, and that's okay. So you have to be able to assess where the patient is coming from, and not necessarily lead them down this whole "what do you think?" that could possibly be annoying to some.
Exactly. Well, it's reading the patient, isn't it? I mean, it's really how to be present, listen, monitor, adjust, dance, etc.
Exactly.
Yeah,
I mean,
absolutely.
it's really relating to what the patient is telling you, and taking the cues from them. And then, since I think I'm the only one that doesn't sit in a clinical situation, I'm outside the clinical setting. So in public health, we often think of a systems approach, and I liked the ideas in this chapter that talked about working with a trained health educator, counselor, or coach, having integrated teams, or at least some trusted referrals that the physician could use as backup. And then also, I think that there are opportunities in public health to work with partners. This is a lot of what we do, is building partnerships with medical organizations, getting their endorsements of motivational approaches, and helping facilitate, bringing more awareness of this, so that there could be more training. I like the example of having sample curricula, which distinguishes some of these approaches, both encouraging a patient to do something like follow a medication regime or get a flu shot, versus not doing something like don't smoke or don't eat unhealthy foods.
Well, actually, Tami, I think we're going to have to move on because I'm watching the time. Sorry about that. But John,
no problem.
Do you have just 60 seconds, because we have a few wrap-up things that we need to do before the end of the hour? So
yeah, sure. So the biggest one for me, or the one that I think is most stood out, was making sure the patient is there, or trying to encourage the patient to be their advocate. Because often they'll say, I went to the doctor, and again, I'm going to be the diabetes patient role here. I went to the doctor and they didn't check my feet, and I always say, that's why when you get there, I want you to take your shoes and socks off. I want you to be ready so that the patient, or so that the provider will remember to check your feet, but also if they don't, you'll be ready if you have to say, can you please check my feet? Be your own advocate by taking certain actions to prevent things from being missed and that kind of thing. So the patient advocate, definitely that one when Sarah mentioned that, that is something that I'm a big believer in. And I'll leave it at that so you can move on.
Okay. Okay. Well, thanks very much.
Sure.
What I was trying to do, and this is an experiment for us in terms of none of us have worked together before, but what we're trying to do in some small way is to sort of create a learning conversation and hopefully generate interest in people developing their own learning communities about how to deal with the complexities of behavior change. Can we move on to the next slide? Now, this is a quick sort of, this is inviting the audience to participate now, and this is, and there's one theme that came up in one of the reflection notes, and actually somebody mentioned this on this webinar, is the whole issue of guilt. How many people have heard somebody say or experienced, as Tammy says, I feel guilty about not whatever it is, and how do you respond to that? And I'm just using this as one example of, engaging our listeners to respond to that. And I'm just going to give you one response to that. When a patient says, I feel guilty about, and sometimes we can feel stuck, and we all feel stuck at different times. So what do you say? Well, whenever you feel stuck, there's a bailout strategy that, I think is extremely helpful, which is simply tell me more about that. And basically what it does is allow patients to tell you more about what's going on. It gives you an opportunity sort of to think through, listen in ways that you can develop a more effective response. So we'll see whether we get any responses to this, but if you would like to type in a response to that particular question, I don't know if people are willing to sort of, what would you say to that? Can you type in a response? We'll give people 1 minute to type something in and see if people are activated to respond to that. How do you respond to that question? We'll see whether there's any responses to that.
Great, thanks, Roy. Can you just repeat the question again so that people know what they're responding to?
Yeah, the question is, when a patient says to you, I feel guilty about whatever it is, not doing my exercises for physical therapy or whatever it is, how do you as a practitioner respond to that question or that statement? So what do you say verbatim back? This is a way of crowdsourcing ideas from our listeners about what's the collective wisdom of our listeners here and now about how you might respond to that. So if people would like to type in some responses, and if you see anything coming up, Dominica, perhaps you could read them out. If we get any responses, if we get them. But again, this is an example of trying to do something different in a webinar, and how do we engage instead of just a simple Q&A where it's just one person asking a question. How can we actually create a learning community about this?
Great. So we have Deborah saying I would ask them to explain that more and why they feel guilty.
Yeah, okay.
We have another one that says, tell me more about that.
Good. That's a good bailout strategy, yeah.
Another one that says, what bothers you about ... Another that says you shouldn't feel guilty. It's normal to not want to ...
So normalizing the behavior. Mm-hmm.
Yeah. Reflectively, I would say you shouldn't feel like that.
Okay.
Well, what might you do to change that is another response.
That's great.
What's preventing you from doing this is another.
Mm-hmm.
Another one says there's no need to feel guilty because every day is a fresh start.
Mm-hmm.
Another is what are some of the barriers you're encountering, and do you have some ideas to overcome those barriers?
Mm-hmm.
What would you do differently? What worked or didn't work? Another response is, it sounds like you have thought about that a lot. And another one says, I would also tell them to not beat themselves up, that people fall off the wagon and that they can get back up.
Yeah, that sounds fantastic. Well, it looks as though we've got some great responses there. But I think this actually speaks to the learning process itself, and this is what we have to replicate in our clinical practice, is how to tap into the expertise of patients or our participants or our learners and create a learning environment where we can share and develop more effective ways of dealing with it. So just in summary, what we tried to do today was introduce a new type of learning process, and maybe we could go to Q&A and then finish up. So I'll hand back to you, Dominica.
Wonderful. Thank you so much, Rick. So we did get a couple questions in. If anyone has any questions at this point for Dr. Rick Botelho or to any of the panelists, please feel free to type them into the questions panel to the right of your screen. You might have to open it up. The first question, Rick, is around how your information that you presented today is different than motivational interviewing or facilitated dialogue.
Oh, fantastic. No, that's a great question, actually. Well, actually, what we just covered is something which is not typically done in most things. This is sort of the preparatory step to developing those skill sets. So, you know, shifting our professional role, for example, you know, to what extent do we go through learning experiences ourselves as a learning community about how to improve our health habits? So it comes back to the fundamental premise of Chapter 1 is learn how to change yourself before helping others. So that's one. The other is the motivational interview is integrated into this. The most recent iteration, and I'm trained as a motivational interviewer, actually isn't fully, because the motivational interviewing over the last decade has evolved and developed, and there's some nuances there that aren't captured in there. But the point of the book actually is to expand the repertoire beyond just motivational interview, the stages of change, but incorporating things from, you know, social learning theories, self-determination theory, and it's really trying to synthesize it in a way that makes it practical for busy practitioners. So I'm focusing on busy practitioners, not on motivational interviewing where you may have an hour with a client working on, you know, an alcohol drug problem. Although motivational interviewing has expanded to all health behaviors. So actually I went to the very first motivational interviewing workshop back in the early 90s. So, you know, I'm very familiar with that. But my target audience is really the busy practitioner.
Okay, great. Thank you, Rick. Another question for you is, what skill-building approaches have you used where professionals can assess each other's skills?
That's another great question. The way in which I like to do that is through setting up role plays where people can go through a process of role-playing these exercises or tasks, video recording them, going back and critiquing them, using some standard forms in terms of how to give feedback to each other. You know, for example, what went well, what were the issues involved that were challenging for you, and what didn't work so well. And both as in the role plays that people can go through a process of critiquing themselves, both as the practitioner and also as the patient. That's a very loaded question, but I have to keep my response brief. But you really have to practice these skills and then observe your behaviors and then go through a feedback cycle so that you can look at, you know, what you're doing well and not so well, and how can you expand your repertoire of skills.
Great. Thank you, Rick. The next question is for Joanne. Joanne, can you discuss the conflict between having curriculum expectations from a recognizing body, such as the ADE or ADA, that you have structured amount of materials in your group classes, versus the ideas presented today about individualizing content?
Yeah, so that gets really difficult because you do have to cover all the content areas. But I think what's important is that there are specific areas where one or, you know, certain participants, you think that they need more, you know, need more attention based on your initial assessment, because usually the way that it's structured is we do have that initial assessment time to get feedback from our patients about what they need covered in class. And that's really the purpose of the assessment. So if you find that there are certain content areas, and usually, you know, we're going to have an idea of what those content areas are that need a little bit more attention than others when we teach class, I would spend more time on those content areas and less time on the other content areas, but make sure you're, hitting on some of the key points. So, for example, if a patient really wants to talk about medications and, possibly being on insulin in the future and wants to learn about that, then maybe you spend a little bit less time on, gosh, that's hard. It's hard to figure out which things to spend less time on, but maybe you spend a little bit less time on complications, but you do talk about each one and how it's affected, how diabetes affects it, but maybe not spending as much time as you usually do. So yes, that makes it very difficult because it is a balancing act, and we do have to make sure we're meeting the standards. But if there's ever a way that we can kind of shrink down to just key bullet points on certain content areas so that we can advance or cover more on other content areas, I think that will help make it more individualized to the patients and to the group that we're serving.
Thank you, Joanne.
Sure.
Rick, the next question is for you. How can this approach work on phone consultants only when there's no physical or nonverbal cues?
Well, you still have to rely on. There's still nonverbal cues that you can pick over. You can through listening to the tone of voice. So there are still those cues. This is a very loaded question because I don't think I can respond to it quickly. But I think there are different methods that can be used for telephonic support. So there might be actually assignments that you ask people to complete in advance prior to the conference call, so that they're activated in advance, and so that when you have telephonic coaching, you can actually focus on something that they've already thought through in advance. And actually that gets into something, my next book I'm writing on at the moment is to actually do that much more effectively. But it's a bit outside the scope of this particular webinar. I'll be quite happy to for that person to get in touch with me if they're interested. But I see we've got about 3 minutes to wrap up. So Dominique, I think we need to bring this to a close and perhaps do the last question, because that was a question we wanted to get a sense from our audience about what's their curiosity in terms of participating in learning communities about health behavior change.
Sure, absolutely. If there's actually just one more question from an audience member, then we can just do the poll.
Okay.
So have you found that it can be detrimental to tell the patients things like, it's okay that you do X, Y, Z, every day is a fresh start, or you can try again tomorrow, as was mentioned, because it may make the patient think that some non-adherence is acceptable, or does that in fact help the patient feel more comfortable with the provider?
That's a very interesting question. I think, I can't come off with an off-pat response to that, because it's so dependent on the patient. I'm not avoiding the question. I think the whole, it's really is taking a position of acceptance of where the patient is and being non-judgmental. And this is a guiding process that happens over time. So I don't have an off-pat answer to that particular question, because I would have to be engaged in the conversation with that particular person, and depending upon their responses, address some of those issues. So it's a great question, but again, that would be a great role-playing one to do. In terms of setting up a learning community and enacting those scenarios and seeing how you can respond to it.
Great. Thank you very much. And I certainly want to encourage everyone if there are any other questions, to go ahead and participate in the Surround Health discussion that has been set up for this particular webinar. And Dr. Botelho would be more than happy to respond there as well. So now we're just going to move on to the one last quick poll about your interest in joining an online community. So you should start seeing it on your screen now. So if you wouldn't mind just taking 30 seconds to respond. Thank you very much. I'm starting to see some responses coming through. Okay, so again, are you interested in joining an online learning community? So the answers are definitely, probably, possibly, and I doubt it. So just give it 10 more seconds.
Yeah, the 70% have voted so far, I see. It's fascinating how you can monitor this.
Okay, great. So we're going to close the poll, and I'm going to share the results with you. Okay, great. So we have 14% said definitely, 20% probably, 38% said possibly, and then 28% said I doubt it. Okay, thank you very much for your responses. So great. I wanted to just take a moment to thank Dr. Botelho and all of our terrific panelists. We hope that you found this webinar very useful. We'd love to hear your feedback. Don't forget that registration is now open for our next webinar, which is next week on entrepreneurial careers in healthcare. We did record this webinar, and it will be archived within Surround Health. Your webinar completion certificate will be available in your profile starting tomorrow, and you will also get a thank you for attending email with a link to that as well. Don't forget to complete your feedback survey for this webinar. It will pop up as soon as you close out of it. And if you are interested in earning the 2 extra CEUs, please post your reflections to each of the chapters in that Surround Health discussion. The last day to do so is Wednesday, 5/14. And you will be receiving a separate second certificate if you're interested in getting those credits. Again, thank you all very much for joining us, and we look forward to you joining us for our next webinar. Have a great day.